Rivera. I'm very glad to give all of you this case. I want to give my applause to the previous presentation that all are excellent. This case was published in a neuropsychiatry magazine from Chile in 2001 with a work team of my colleagues that we work in this article. Okay, so we start the personal data of this patient. She's years old, female from Panama. She is a teacher, religion Christian Catholic. She has social insurance and she is single. On the reason from consultation, she was aggressive, talks about Lucifer, leaves the house to jump into the cars, and hear voices that tell her to kill herself. While in the current disease, as you know, a female 20 years old, she doesn't have any pathologic history background. She had 2 years of evolution of decreased need for sleep while restless, organizing her things as a teacher. Then 2 months ago, with intense frontal headache, with a strong head in her life associated with gastric symptoms. 1 month ago, previous the hospitalization, at work, she was vociferous and irritated with her students. At home, she was disruptive, irritable, physical and verbally aggressive towards her relative, mystical religious ideas. I talk to Lucifer and he gives power, and placing photos of rockers from the 18 at decapitated people in the room, and increased decrease in the need for sleep. Behavior changes like wearing black clothing and lipstick, and arriving late at night on weekends after going out with friends to nightclubs. And in all her medical history, both psychiatry and non-psychiatry, all are denied. The only close is family history with a distant relative with possible Alzheimer's disease. On her psychobiography, she got a good neurodevelopment, no complications in her growing. She finished the college, and her primary personality was respectful, few friends, and very calm. Mental status examination, in her appearance and behavior, the patient was in the emergency room, in the stretcher, restricted in 4 points, with apparent age according to chronological age, wearing hospital clothing, observed with baggy eyes, anti-flat hair, little expressive face, poor cooperation, suspicious, with perplexed gaze towards the ceiling. She was awake, and memory irritation imperative, and for a moment she was with psychomotor agitation. On the language, Spanish, oral, good diction, soliloquies, and at times loud and vociferous tone of voice. In her thinking, she was tachypsychic, desegregated, incongruous plurality, with delusional ideas, mystical religious type. Lucifer have the power, mood effect, irritable with super aggressiveness, sense of perception. She doesn't comprehend, but she has an impression that she was auditory and visually hallucinated. Her critical judgment was divided, detached from reality, and of course, well, or a negative, even her electroencephalogram. Now, when we see the image, it was very interesting because a patient with no background of psychiatry or other medical illness, it's always in our field to discard the neuropsychiatry or organic etiologies. And we found, well, in the cat, Galassi Type I Arachnoid cyst in the left temporal lobe, middle cranial fossa. But for us, it was like, hey, it's kind a little big, right? So we talked to the Santo Tomas Hospital, and they helped us with magnetic resonance, which of course that diagnosis changed to Galassi Type II, and as all can see, the key is displacing all the temporal lobe. And when we review a little of Broman area, she has dysfunction in the 28 area, which causes dysfunction on the emotion of in this particular case. So she had 2 weeks of hospitalization, 40 days. Of course, at the beginning, she was cooperative, restless with a frank psychosis. Even we suspect a possible seizure with tonic rigidity, with puzzle look for a few seconds. She was then improving. We changed to oral medication, and we changed olanzapine to risperidone because the somnolence effect adverse. We had heard the valproic acid for suspicious of the seizure, plus mood stabilizer. She then cooperated with the neurological absent that we saw in her right nystagmus. And then, as I told you, she went to the Hospital Santo Tomas that helped us with the electroencephalogram, and she got evaluation from neurosurgery that they decided conservative management. We did later a cognitive screen, the MOCA, and we see failure in the attention and concentration. And the medical discharge, she's improved a lot in her symptoms, but still have difficulty managing frustration and impulsiveness. And the patient acknowledged that she did things without meaning, heard the voices, and had difficulty controlling her anger. The treatment was for outpatient risperidone 1.5 age 12 hours plus valproic acid 1 gram age 12 hours. Now, on discussion and the diagnostic review, we know the literature say that Arachnoid cysts mostly are asymptomatic and incidental finding. They are 2 types: primary, which are congenital, and secondary, external causes like trauma, infections, or cerebrovascular disease. And symptoms, psychiatric disorders have been seen, and other symptoms like headache, seizures, local neurologic deficit, amenorrhea, and most of symptoms are in the pediatric population. But in our patient, we saw headache and seizure plus the neuropsychiatric possible symptoms. Those cysts are prominent in the middle cranial fossa on the left side as our patient, and the Galassi classification of 3 parts: type 1, the small cyst; Galassi type 2, moderate size, triangular and quadratic shape; and Galassi 3, large round or oval size. So what about the neuropsychiatric symptoms? The literature do a lot of evidence. First, symptoms like schizophrenia with delusional ideas, like paranoid ideas, auditive hallucination, and anxiety. We have anxiety and depression. Both share a common neurocircuit in the brain, a dysfunction in the frontotemporal lobe with reduce of the gray and white matter reduction structures. So at the end, the neuropsychiatric symptoms will depend in the size of the cyst. And here is to show you that there are a lot of tools like PET, SPECT, and electroencephalogram who demonstrate the alteration or dysfunction in the brain, and both share the dysfunction in the frontotemporal lobe and the reduction in the area of the white and gray matter reduction. Here in the symptomatic review from the magazine World Neurosurgery of Korea. They evidence the symptoms, and I put the ones that we saw in our patient, like headache, psychosis, the possible seizure, and of course, left area affected, and the Galassi Type II. So here I share with you a table that we made from different articles that share the similar case clinic. And from the red ones, neurosurgery decide a conservative management, and the ones with the blue, neurosurgery intervenes. And interesting because the ones that were conservative, they did not improve their symptoms with medication, maybe a little. But when the neurosurgery, when the surgery intervenes, then the article mentioned the improvement of the symptoms, psychosis, mood, humor, and all the psychiatric symptoms. And now I share the different imaging from the different article. So you can see that it's a big cyst, and is congruent with what the literature and mention about the symptoms and the size. And it's very interesting because in the number 4 patient is a patient with schizophrenia, and the article mentioned that in all its diagnosis, they never did an imaging, but because a lot of relapsing, they made an imaging and they found the cyst, and after surgery, the patient improved. So in discussion, our patient is at a young age, where there's a probability on the psychiatric symptom, schizophrenia or mood disorder or affective. She has no antecedent. She had adequate neurodevelopment, which means there is no genetic load or stress that affect her vulnerability so far. We don't rule out a possible organic cause, as in the different articles, there is no certain evidence of whatever these cysts are the main cause of exacerbation or not of psychiatry versus psychiatric symptoms. It is impressive that the surgical intervention could help in the improvement of the symptoms. According to the literature, further with this patient, it would have been similar, and despite that improvement with the treatment, impulsive and allotolerance for fluctuation still persisted. So at the end, we give the diagnosis, acute polyphonic psychotic disorder with subsymptom of schizophrenia versus organic mood affective disorder, epilepsy, and the Arachnoid cyst type II. And conclusion, in our specialty, our patients are aware and complementing the studies are a tool for proper diagnosis and treatment. Between the organic diffusions versus psychiatric alteration, they share similarity of symptoms for which the clinic is important to differentiate the possible etiologies. The importance of blood tests and complementary studies and psychiatric patients is a diagnostic help. The clinical case is one of the few reported in the literature where the symptoms presented have a high probability of being caused by structural diffusion, and its follow-up in the outpatient clinic could give us a possible answer to the diagnosis in the future. And the neurological examination is an important tool according to the patient. So this is the reference. Thank you, and I share a bit of my cultural outfit here in Panama. Any question, you can do it. Thank you.
Thank you, Doctor. That was an excellent